Good afternoon, everyone. I'm Linda Cheung. I'm the clinical pharmacist for infectious disease here at the James A. Haley VA. And today I wanted to give you an update on influenza for this new season, 2013-2014, that we just started. I thought this was a timely topic to talk about because we've actually started to see some cases here in our area. So just to refresh your memory, remember the Spanish flu from 1918 was the most significant infectious disease outbreak known to man. It killed 40 to 50 million worldwide that year, half of which were in young population in their second to fourth decade of life. So it affected very many young individuals, and 500,000 of those were here in the U.S. And it was caused by influenza A, H1N1 virus from an avian origin. And since then, there's been several that some of you may recall. Pandemics, first being the Asian flu from 1957, also caused by influenza A, but the subtype H2. And this was seen in patients who were co-infected with H2N2 and H1N1 at the same time. So that was something different. It accounted for about 4 million deaths worldwide. In 1968, the Hong Kong flu, caused by influenza A H3 subtype, attributed 2 million deaths. And then about a decade and a half ago, avian influenza, caused by influenza A again, but H5 subtype. And they found occasional human-to-human transmission with this one, but they could not associate this with aerosolization. So if you look at the epidemiology of influenza and the annual impact, we know that it's most common in young children and then elderly. So any third of the cases are reported in children, and then in elderly patients greater than or equal to 65 years of age. There's about 25 to 50 million cases per seasonal influenza epidemic, accounting for greater than 200,000 hospitalizations per year, attributing greater than 36,000 deaths per year, and economic burden of about 87 billion. So, you know, this disease causes a lot of healthcare resources. In 2009, if you were around and doing ID, you may recall the H1N1 and some of the issues that arise with that epidemic, resistant Neuraminidase Inhibitors. We didn't have enough vaccine to go around. We didn't have enough drug to treat patients, so it was quite chaotic back in 2009. After that season, they were actually able to do epidemiologic studies and evaluated that outbreak and attributed it to predominantly morbidly obese patients with BMIs greater than 40 and American Indians, Alaska Natives. So I thought that was pretty interesting. So influenza viruses, there's actually 3, type A, B, and C, and they're all members of the Orthomyxoviridae family. Influenza affects humans, pigs, horses, and birds primarily. In humans, the 2 types are influenza A and B, and there's various subtypes that are out there, as you know. H1N1, H3N2, H5N1, and I think there's a H7 and H9 out there too. You know that influenza is highly transmissible through respiratory route, and we see this in our yearly winter epidemic, which starts in the late summer, early fall. And it goes on through probably spring, March, April of the following year. There's 2 phenomenons that are known with influenza, one being antigenic drift and one being antigenic shift. And the reason why we have to vaccinate patients every year is because of these phenomenons. Antigenic drift is a continual process. So there's a point mutation in the virus, and every year it's just continually changing. So the vaccine that's produced does not offer prolonged protection. And therefore, we have to get yearly vaccines for this. and it can also cause changes in susceptibilities of the antivirals. Antigenic shift, on the other hand, are normally sporadic changes. They're usually unpredictable, and it's usually due to a mutation of the hemagglutinin or the neuraminidase from the animal source where it came from. This has no immunity within the patients, or there's no immunity produced in the population when there's an antigenic shift, and therefore this can result in a pandemic. So this was as of last week, week 43, October 26 ending, and this is the flu activity in the United States. Widespread is sort of more in the dark brown. So as you can see, there hasn't been too much flu activity in the United States in the last month and a half. There's been sporadic cases reported throughout the United States and some local regional cases that have been reported. But other than that, there hasn't been widespread reporting of influenza this year. And this is looking at the various subtypes as of last week. Predominantly this year, we're seeing influenza A, with some 2009 H1N1 being reported, and minimally influenza B being reported. This is looking at positive tests. So I think there was a total of a little bit over 500 tests reported to the CDC, predominantly subtype A, and some H1N1. So those are the two major ones that have been reported as of last week. Okay, so when we have a patient who presents and we are suspecting influenza, there's essentially 5 assays that are available for diagnostic. 3 of which are used more routinely, and 2 more so for epidemiological reasons and research reasons. The main difference between the 5 methods is the turnaround time. Here on the right, as you can see, the rapid antigen or diagnostic test turnaround time is within 30 minutes. And that one it's CLIA waived, so you can actually do that as a point of care device in a home setting or a clinic type setting. Whereas the others, the turnaround time is a lot longer and they are not CLIA waived, so they have to be done in a laboratory. So the one you guys are most familiar with is going to be the RAT, or rapid antigen test. You would use a flocked swab. This is a swab that's available in the clinic. It does not have to be refrigerated. It's usually just in the clinic on the shelf somewhere. And this is a nasal pharyngeal swab or a nasal swab. And the turnaround time, like I said, it's pretty quickly. It's simple and easy to do. However, the limitations are it's only about 50 to 70% sensitive. And during periods of early season or late season, when you have reduced number of influenza, you're going to get a lot of false positives, or when patients are truly negative. So you got to be aware of that. And during peak seasons, in the middle of your influenza season, you may get a lot of false negatives. So there's going to be some limitations with this assay. And it's ideally, you should be collecting this sample within 3 days of the exposure to get the best results. Also, in children, it's been shown to be more specific and less specific in adults. So those are a couple of major limitations of the RAT test. Our lab uses the RAT test that detects both influenza A and B, but there are tests out there that only detects influenza A. So wherever you go, you need to find out which one your lab uses. The other 2 tests that you're probably familiar with is the viral culture. This is also a nasopharyngeal swab. It could be a throat swab. It could be a bronchial washing nasal aspirate or sputum. This is the one you're going to get a panel of viruses. You're going to get adenovirus, parainfluenza, RSV, and it gives you a whole panel of different viruses. And it also gives you the influenza and the subtypes. This one has to be collected in M4 media. So if you sent a flock swab down and asked for a viral culture, they cannot do it because it has to be done in this special media. The N4 media has to be kept in the refrigerator. So either you need to go down to the lab and get a M4 media and do it yourself, or have nursing or whoever go down and get one. This is the gold standard test. It's rather expensive. Here at the VA, we don't do it in-house and we have to send it out. So the turnaround time is about 7 days before you get your results back. The last one you're probably familiar with is the PCR test. This one is most sensitive. And again, it requires a special media. It's called the UTM media. It is becoming more widely used, and the results are usually available within 2 to 4 hours. This one we do in-house here at the VA. So if you order this, you should have the results pretty readily. The other two tests, the DFA and the serology test, like I said, are more commonly used for epidemiologic studies and also clinical trial type settings. The DFA requires intact cells and laboratory skilled personnel to perform the test. It's very sensitive, but there's some limitations of the test. And the serologic test, you actually have to get 2 samples and follow convalescent titers on. So again, these 2 tests are not as readily used in a clinical situation. So before we start talking about the drugs that are available for the treatment of influenza, I sort of wanted to walk you this diagram from New England Journal of Medicine 2005. On the top panel, you have the infected cell, host cell, and you have a virus which is about to bud off to infect other cells. There's a point with the computer. No, it's not working. Anyways, okay, so the virus is going to bud off to go off to infect another cell. At the receptor, salicylic acid receptor, that is where the virion is detached. And on the surface of the virion, you have proteins, hemagglutinin, and enzymes, neuraminidase, which allows the virion to be cleaved off to go infect another cell. On the bottom panel, panel B, what happens is when you give a patient neuraminidase inhibitors, it blocks the enzyme neuraminidase so that when the receptor attaches, it's no longer able to detach and go off to affect other cells. And the process is halted at that point. So there are 2 neuraminidase inhibitors on the market. They both cover influenza A and B, oseltamivir, Tamiflu, and zanamivir, Relenza. The major difference between the 2 as far as treatment in adults is the zanamivir is contraindicated in people with respiratory diseases because it's only available as an inhaler, which I'm going to show you in a minute. So in patients who have asthma or COPD, you should not be using the zanamivir. So neuraminidase inhibitors have been on the market probably, 15, 20 years now. And the studies that looked at the outcomes of patients that were treated with neuraminidase inhibitors show that if a patient has influenza and you put them on a neuraminidase inhibitor, their symptoms actually are reduced by only about 1 to 1.5 days. Okay, as long as it's administered within 2 days of illness. So they do see a mild benefit when they're treated within the first 48 hours, and it does reduce lower respiratory tract complications, pneumonia, and hospitalizations. And oseltamivir has been shown to reduce mortality amongst hospitalized patients with lab-confirmed seasonal influenza. Neuraminidase inhibitors' effectiveness against H5N1 is unknown because back in those days they weren't really studied against H5N1. Just wanted to highlight here on the far right-hand side, each of these agents can be used for treatment or prophylaxis. If you're using oseltamivir for treatment, it's 75 milligrams BID in adults. And if you're using oseltamivir for chemoprophylaxis, it's only 75 milligrams once a day in adults. And we're going to skip the children because most of us in this room don't, our practice do not accept those of us that have kids at home. And then zanamivir, again, same sort of thing. If you're treating, it's BID dosing, and if it's chemoprophylaxis, it's once a day. Okay, so this is also Tamiflu. For treatment, it's BID times 5 days, and you can consider longer treatments if patients are severely ill after the 5 days. Prevention, it's once a day, and it's usually for 10 days after their exposure. It comes in capsule form and also oral suspension if you have a patient that cannot take caps, because it was made in oral suspension for children, but we use it in adults as well. Major side effects are going to be nausea, vomiting. There were some case reports of delirium in adolescents, but mostly in reports from Japan. And since 2007, Tamiflu has had to add that to their package insert and labeling. The precautions you should take with oseltamivir are that in patients with kidney disease, you do need to doses adjust for kidney disease. And the safety in patients who are pregnant or nursing is still unknown, so it's not recommended to use in females who are pregnant or nursing. Now, resistance has been reported with oseltamivir, and it can be developed during treatment. So be on the lookout for patients that relapse or have no improvement on treatment. If that's and during the resistance was uncommon prior to the 07-08 season, because in 09 is when all that resistance developed. Relenza, this is the oral inhaler form I was alluding to earlier. This is only available as an oral inhaled powder. So when they squeeze, it's actually a powder that comes out. And it may not be suitable for severely ill patients. If they're intubated, they can't inhale that powder. And it's contraindicated in patients with COPD or asthma. Major side effects, reports of allergic reactions being oropharyngeal or facial edema has been reported with zanamivir. Besides nausea, more side effects than the oseltamivir being diarrhea, sinusitis, more upper respiratory type symptoms, the nasal signs and symptoms, bronchitis, cough, ear, nose, and throat infections, wheezing, all of these things have been reported with the zanamivir. Same delirium warning is in the package insert, and it's because the FDA thought that this could be a class effect because of the reports from oseltamivir. So they've had the makers of Relenza put that in their package insert in 2008 as well. Same warning with pregnancy and nursing mothers, so do not use because we do not know the effects of it. Okay, just want to spend a minute going over Peramivir. It's an IV formulation. It's available for emergency use with the FDA approval, and we've actually used it once here. It's only indicated for the 2009 H1N1 strain. It can be used in adults or pediatrics. And because it's only available as an IV formulation, it's normally indicated in hospitalized patients, of course. And with the approval, you fill out this form, and the FDA is going to ask you why you need it. And basically, they're looking for, the patient hasn't responded to oral or inhaled therapy, and or the drug delivery by the other routes are probably not as effective or not feasible, and you're requesting Peramivir for IV use. Once the approval is completed, then they will ship and send the drug to the hospital for that particular patient. And the authorization terminates after that patient completes treatment. So once you apply for it, you have to do it for every patient that you put on. It's not a one-time and you're covered for the rest of the year or anything like that. So vaccinations, I want to touch on vaccinations because this year there's a lot of different influenza vaccines out there, and it's sort of confusing. In February of this year, the Vaccine and Related Biologics Advisory Board, which is a subcommittee of ACIP, approved the vaccine for this year, influenza season 2013-2014. Compared to last year's season, the A component is identical to last year, so it's still H1N1 and H3N2. The B component is the one that changed for this year. So they changed the B Massachusetts strain. It's a different one. And this year, for the first time, we also have a quadrivalent vaccine available in the market, which has an additional B strain vaccine. So if you're giving a patient a quadrivalent vaccine, you're essentially giving them 2 A's and 2 B's. Okay? So influenza vaccines in the U.S. for this season, there's 3 trivalents on the market and there's 2 quadrivalents on the market. The trivalent ones can be given IM or intradermal, mostly indicated for any person greater than or equal to 6 months, and if they're less than 9 years, it's recommended to give them 1 additional boost 1 month after their first immunization. There's the standard dose trivalent and the high dose trivalent, and I'm going to go into what the high dose, the difference is in a minute. The high dose is indicated for individuals greater than or equal to 65. It's actually 4 times the amount of antigen as the standard dose, and 4 times the price for that matter. And also for trivalent, available this year is a recombinant influenza vaccine. The quadrivalent, which is new this year, is not indicated for individuals less than 6 months. It does come as a standard dose, quadrivalent, and then also comes as a live attenuated for intranasal administration. The problem with intranasal administration is you do have the risk of viral shedding after the administration because it's alive. And then you should not be using it in immunocompromised individuals, of course. And then there's more rhinorrhea, congestion, sore throat because of the inhalation. Okay, so high dose vaccine and where do we use it and what are the implications? So in the elderly population greater than 65 years of age, what these 2 studies indicated were as we age, we have declining humoral cellular immunity, which causes us to have increased susceptibility to infection. Even if we vaccinate patients, we see a reduced immunologic response to vaccines. And it's shown here, the unadjusted, which is the dark bar, is individuals between 18 and 59 years of age, and the white, which is the adjusted, is the elderly patients greater than 60 years of age. And what they're seeing is they have a reduced seroconversion and they have reduced seroprotection just because of age. So the high dose vaccine was studied. It was published in 2009, Falsey's article out of JID. And what they showed was in patients who are 65 and older who received high dose vaccine, and like I said, it's 4 times the concentration of the standard dose, they had increased antibody production, and the proportion of persons who successfully were considered immunized were much higher in the dark blue lines than in the light blue lines in patients who received the light standard dose. So the CDC advisory reviewed this the latter part of 2009, early 2010, and they came up with this neutral recommendation that if you have a patient who's greater than 65 years of age and you think they're a high risk, you you can use the high-dose vaccine, but they don't follow that up with a strong recommendation that you should use it in elderly patient, and that's primarily because there's no outcomes data. This is strictly based on measurement of hemagglutinin concentrations and neutralizing antibody concentrations in these individuals. The last I heard, the outcomes data was being collected, but it's being postponed, so it may not even be available until 2014, 2015. So we I think it was last year, 2 years ago maybe, we ordered some. It wasn't very well received. A lot of the providers didn't think patients needed it. We had it available. This year we didn't order any at all. With the high-dose influenza vaccine, there has been reports of more local reactions. So if you give it, there's been more pain, erythema at the injection sites that's been reported. Although primarily they've been mild, and most of the time these reactions resolved within 3 days post-vaccinations. So if you looked at them 3 days and then 7 days, the two lines were equal as far as reactions go. This year also, there's recommendations for influenza vaccine in persons who report egg allergies. That's always been something that patients said they couldn't get influenza vaccine because of the egg allergy. So this year, the ACIP came out with this algorithm for patients with egg allergies. And up on the upper left-hand corner, the question is, can the person eat lightly cooked egg without a reaction? And one of the questions they suggested you ask is if they can eat baked goods, because a lot of the baked goods like cake and things like that actually have egg in it. And if they can eat that, then chances are they're probably okay. So the question is, can the person eat lightly cooked egg without a reaction? And if they can, then it says go ahead and administer the vaccine per usual protocol. If they can't, then after eating eggs, you're supposed to ask them, do you get a hive? And if they don't, then again, you can give them a recombinant vaccine if they're 18 to 49, or just give them the inactivated influenza vaccine. And then lastly, if they are really allergic to egg, they have cardiovascular changes, respiratory changes, GI, and require epinephrine, emergency medical attention, then obviously they need to have the recombinant form. So this was new as of this year. And then lastly, in pregnancy, I just wanted to touch women who or will be pregnant during the influenza should receive the inactivated influenza vaccine. Live attenuated is not recommended during pregnancy. Postpartum women can receive live attenuated or the inactivated, and then pregnant and postpartum women do not need to avoid contact with persons recently vaccinated with the live attenuated. So if someone got the live attenuated intranasally, they don't need to avoid them, or because I get that question sometimes too. Okay, so in summary, the FluView or the CDC updated weekly is something you guys should be checking on a regular basis because you need to be familiar with the flu activity in your area and the trends for this season. So I would highly recommend that. Look for potential for additional guidelines based on emerging surveillance data. For example, in 2009, when we started seeing resistance to oseltamivir and some of the resistance and trends, we had to sort of guide providers as to what to do in the primary care setting. Stay alert to additional changes in antiviral recommendations and local trends. So all the cases in Hillsborough County are reported to the health department, and then they in turn report it up to CDC. But you should be familiar with what's going on in Hillsborough County if you're covering the hospitals in this area. And then our goal as our ID practitioners is improve this communication. Here at the VA, we get a weekly update of flu cases in the VA system nationally, so we know which states have high activity and which states have low activity. So it's a good idea to kind of stay alert with what's going on as far as that goes. Use local surveillance data, clinical judgment, and the rat to guide the choice of antiviral regimen. Realize early on and late, you're going to have a lot of false positives. In the heat of the season, you're going to get more false negatives. So know how to use those results. And then monitor for severe infections or unusual outbreaks involving oseltamivir resistance virus. Although influenza viruses that were resistant to oseltamivir in 2009 did not appear to be more dangerous or infectious than susceptible strains.